So good afternoon, everybody. Thank you so much for joining us. This is the Hit Like a Girl in cooperation with Dream Big's Black Maternal Health Week Fireside. And I'm so excited for the women that are in this room. I'm so excited for this conversation. As you guys know, it's a very important conversation. So we're hoping that today's conversation will get some actionable steps out there that we can all look forward to and get actually working on this particular problem of Black maternal mortality. So let's get right into it and ask our guests to please introduce themselves, starting with Fran.
Sure. Hi, everybody. I'm Fran Ayala Somayangela. I'm the president of REACH. We are a global social impact organization that is focused in four core areas. The first of which is in health equity, clinical empathy, clinician burnout and resilience, as well as in the digital application of data science. And with that, a big emphasis across all of those four areas is how they directly impact maternal health. So I'm really excited to be able to talk to that today during the Fireside Chat.
TJ, let's go to you.
Sure. I am TJ Southern. I am a registered nurse. I'm a nurse informaticist. I am the owner of Barillas Consulting and Staffing. And our mission is to take all of these data points that we are actually getting from the healthcare record as it relates to our Black mamas and analyze that data. So that is the importance of having a nurse informaticist, and that is what we do.
Holly.
I'm Holly Varnell. I created the Dream Big initiative, driving equity for all moms and babies by improving gaps in maternal care. It's a clinical quality and accountability initiative that focuses on early access in prenatal care and also providing person-centered care with risk stratification, both with socioeconomics and some molecular diagnostics and phenotyping tools. And at the same time, with these clinical quality measures, I'm collecting data, or we are collecting data at the same time, who participates in it, to find new ways that we can be proactive in care and change outcomes with early access and prevention. We also do digital tools such as clinical decision support. So it automates for ease of use for a provider. It assists with patient outreach and patient education to help build that trust between the provider and patient, and also provide additional resources. Overall, promoting health equity to reduce those disparities in outcomes.
Thank you. So thank you, ladies, for joining us today. Let's get right into it. So we've all seen the numbers. They're all a little well, more than a little disturbing for all of us. But I wanted to ask first off the bat, the mortality rates for Black women in particular have continued to rise. And how do you think we ended up here in this particular time and space? I'll start with Fran.
Yeah, sure. So how did we get here or where we are today? I think it's because we're putting more emphasis on the numbers and not enough emphasis on the prevention. I mean, if you look at the numbers where they are, globally, 80% is preventable. Here in the United States, 60 to 65%. Some would argue 75% is potentially preventable. So it's really getting to, well, what are those preventable measures and ensuring those are taken into account and there's an emphasis placed on them. And to date, unfortunately, we've sort of neglected that. Maternal health, alongside with women's health in general, is, the least, we're the least attentive to. And so much more needs to be done. And I'm glad that we're having this conversation today, because Sharice, you're always very good as a moderator and getting us to start talking about the how-tos as opposed to what's the problem. We all know the problems.
So TJ, would you like to add to that?
Sure. I think because we are, as Fran has stated, we have focused more on the numbers instead of the prevention. It has caused in our healthcare system a negative infinite feedback loop. And that is why our numbers just continue to rise. We've got to break that cycle of that feedback loop by finding, like Fran said, those areas of prevention and really honing in and focusing on those areas.
Thank you.
And of course, I'm going to talk about numbers, but let me put it back in perspective of, I do agree with the prevention. And in the space that I'm in right now, I'm flirting with or exploring possibilities of linking preterm birth to some of these rates, specifically linking suicide rates and opioid addictions to depression and anxiety from preterm births and complications, and then infant death mortality. Preterm birth is the leading cause of death for Black infants, and it's the leading cause for children under the age of 5 globally. It's associated with a lot of different familial, social, socioeconomic related costs and stress that just add to that. And then, of course, with Black mothers being 1.5 times more likely to have a preterm birth, Black infants being 2 to 3 times more likely to die, it trends. It all kind of starts to come together. And when I was looking it up, the pregnancy associated death and homicide is a lot higher than I thought it would be. And then also the mental disorders, I think it ranked at about 6th or 7th on leading causes for maternal mortality in a few states in an early study. But with that, I think it's a huge contributing factor, and we need to start looking upstream with stuff like the Dream Big initiative.
Well, your point about mental health brings up an important topic. As we're going on to question 2, medical gaslighting and the trust issues that women of color have with the medical community. Has that hurt maternal care, and how does that fit into the landscape? Anybody?
Yeah, so let me jump in for a second, and Sharice, I hope you don't score me for going back for just
No, it's fine.
just a little second here, because I was actually going to hop in on some comments that were made there around the infant deaths. So the delay, I want to be first clear about what we actually know as being the statistically significant contributors that are not actually related to substance abuse or suicide and other challenges that women face, but are in fact related to not having the knowledge around signs and symptoms. So health literacy being a challenge area. The second of which having difficulties related to transportation, whether that is women, for example, in rural areas who may even have to drive themselves to get service that may be as far reaching as an hour away from where they reside, or whether you're in an urban area where equally the challenges of having access to transportation cause problems in 2 factors: one, getting to sites, but also in your choices that are available to you in terms of who's providing care for you. Thirdly, we have this issue of delays in diagnosing and misdiagnosing. And fourth, there is the challenge of delays in treatment. And when you actually statistically look at what are the biggest contributors are for both mortality as well as morbidity, it's those latter components. Dare I say, issues around competency and skills and abilities related to the clinicians themselves. So that's where the real problems are. That's why we can confidently say that over 60% is preventable, because these are the areas where we're seeing the problems. And undoubtedly, if we continue with that, right? So now going to Sharice's question around mental health, if we carry on with that and recognize that clinicians are, number one, are delaying in terms of doing the proper assessments for conditions such as depression, whether that is during pregnancy or postpartum, that's a prime example. Diagnosing too late, as well as not provide for that continuity of care postpartum, are big contributors to the problems we're having. And I would think, TJ, that you'd be nodding on this, because I know as first and foremost, as a nurse, and then as an informaticist, bringing those 2 worlds together, that undoubtedly shows up in the numbers that you've been looking at.
Absolutely. Absolutely. So when you talk about gaslighting in that medical arena for those moms, what generally happens, and a lot of times those moms receive, well, they'll tell the providers what their symptoms are, and the providers will just attribute it to something like, regular normal heartburn, right? Because in our culture, it's not given any credit. So that's how in turn it creates the delay in care, because this mom told you what she had, the doctor kind of just pushes it off, and then we start this cycle, right? We start back down this road. And so we are able to actually see those points when the moms come in and they give the providers their signs and symptoms the first time. We're actually able to see it because the provider has to actually document those signs and symptoms during their initial visits. And so that is the point of making sure that we have the correct data points, because when you don't have the correct data points, it doesn't give you a full picture. It doesn't give you a full story. And so then in turn, what it does is it leaves us grasping straws in order to help the situation or change the situation.
There's something really disturbing that I'll add to that is there's a Today show called Dismissed, and there was one story about a woman who was vomiting daily. She saw 6 different doctors, I believe. And I think one of the doctor's statements was, that's a good thing because you need to lose weight, like just completely dismissed. And it took the 6th doctor to actually diagnose her. So I think it's something that happens and affects all women, but I also think it is extrapolated, obviously, in different populations. I think one of the things we could start to look at to help with that early risk assessment and early diagnoses is creating incentives and provider templates for them to follow. And of course, that provider education.
So let me speak to that really quick about those templates and, that documentation. A lot of times the documentation comes from CMS standards, right? Or other healthcare organizational standards. And it has been stated many times before, when those moms are in primary care or they're coming in to see the primary care, it's all about the numbers. They want to get them in and get them out. They really don't take the time needed to actually look at the whole picture of the mom. And so that is why we end up having moms slip through the cracks, right? Where they need case management services, where they need wraparound services, such as Fran said about transportation. So even in the fact of, because I've been on that side in healthcare systems where we have actually implemented forms for the doctors to fill out, I can say probably a good 75% of the time, I'm still having to go back behind doctors and say, hey, you missed these points. Hey, we need this information.
Mm-hmm. I think that's a valid point. And that's why, it kind of brings me to question a little bit. Well, we're talking about creating birth-friendly environments. Well, what does that really mean? What does that look like? I also think that, again, using, if we want to refer to the data, well, yeah, we're talking a lot around the numbers of mortalities, which is in, the 700 to approximately 800 deaths a year. But for each one of those, there's another 10,000 women who are suffering, who survive, but they suffer. So at 10,000, we're talking about 70 to 80,000 women who are suffering with some form of morbidity. That is some injury that may have occurred. And some of that actually not even getting counted because it's post-traumatic, right? Postpartum traumatic situations and syndromes that they're dealing with. And so it just makes me really question, when we talk about creating these birth-friendly environments, what does that mean? Does that just mean a woman just happens to survive the horrors of what she might have had to undergo during her birth, labor, and delivery? Or is it something more? And should we not be expanding that to not only reflect in acute settings, but also in ambulatory settings, so that all the prenatal care equally should be around prenatal friendly, to ensure that all of the data points, as Teresa is calling out and that Holly has acknowledged, are actually getting documented. And if this weren't a problem, then we wouldn't see the CDC's emphasis on Hear Her, which is an entire program focused on ensuring that not only are people in the families and communities of women listening to women, but that clinicians are in fact listening and responding and expressing empathetically to women. And that's really important.
I want to clarify too on the provider template a little bit more of the whole purpose of creating this clinical quality language is to be able to make it interoperable. And part of the building the trust gap and the access and the reach outs prior to even prenatal care is making sure that it's in a template that the patient can actually input. But with it being in that correct language that the patient can input it and then it translates into provider record, then it actually shows up and pops up things like clinical decision supports that are associated with evidence-based medicine and stuff like that. So the provider template is more of a how-to guide. The template itself should be completed, I think, by the patient.
That's all great information that we all need, but I always say it has to start, everything has to start with the patient provider relationship. If we're going to get any of this data, that relationship has to be sacred and has to work. And that speaks to cultural competency. I wanted to take a pause from the panel and invite Lauren Deutsch to speak to the medical education side, because a lot of what we're dealing with has to do with the clinician being able to interact with Black moms. Lauren, would you give us your opinion on how medical education fits into the scheme of this?
Sure. Hi. I've worked in medical education for about 30 years, and the focus of the work that I do is on minority medical education, specifically relative to representation, inclusion, and diversity. And so one of the things that we find over time is just even looking at M1, M2 students in their first couple of years of medical training, and sort of how information like clinical vignettes are presented, or how case vignettes are shared, and kind of what the content of that information is. So even within some of the training that students are receiving, there's implicit and explicit biases that kind of come out immediately. And what we're seeing now is, and what we're working to do, is certainly to have that be an open conversation and to change some of the vignettes so that they're actually representing what is accurately going on, and not sort of an inaccurate or a biased perspective. And so that's one element. But I think the other part of it is along the lines of training. There has to be a culture of openness and not silence around mental health issues. We have to be able to ask questions like, how are you feeling? And actually get answers and help people to discuss, information that is otherwise considered either sensitive or taboo or not okay. And I don't think that means we normalize it. I think that means that we have a shared language that we learn to develop. It's that we say, how can we talk about this in an open way where there's not judgment, where there's not, implicit bias, or where there isn't a rush to diagnose or pathologize. The earlier presentation, or the earlier point about somebody seeking health care, and it's taking 6 doctors just to say, wait a minute, throwing up every single day, maybe that's not okay, maybe that's not right. And that part obviously should not happen ever. So I do think the other piece of this is training doctors in bedside manner and making sure that there's an awareness of having conversations that are difficult to have, perhaps, but don't have to be. And I don't think that needs to be scripted. I think that can just be about training in curiosity, training in, how you do a H&P, and making sure that from that perspective, the history gathering is done with sensitivity and not just sort of pro forma. So I guess those would be some of the thoughts I have. I know I could say a lot, but I don't monopolize here.
Thanks, Lauren.
Well, are we clear to comment on that just a little bit, Cherise?
Yeah, sure.
Yeah, because I think Lauren has brought up some really valid points, right? I mean, first off, from a health literacy perspective, we know that regardless of whether it's a woman during pregnancy or not, patients in general, 80% of the information that's relayed to them is forgotten. And the majority of that is in part forgotten because it's not really understood. And so being able to provide content and present it in ways that are easily digestible and make it simple for comprehension is very important. And that's why having multidisciplinary care teams is so instrumental and really making sure that takes place. When we started to talk about the sensitive conversations, because equally, we look at complications during pregnancy, we do need to look at the things that are contributing that sometimes are difficult to talk about, like weight management and obesity. I know that does affect approximately 20% of women. And so how do we have those conversations when clinicians are typically, or they're just not trained? It's not part of the curriculum to train on emotional intelligence, to train on expressive empathy and responsive empathy. And we know that this comes up as a problem because at REACH, we conducted a study over 2020 and 2021, where we had over 1,000 women participate. And the outcomes of that showed that, we had a number of women, it was roughly 15% of women who said that they felt that their clinician didn't care about them and didn't care about their baby. And we had over 20% who said that if they had been given the opportunity, if they thought that they could change clinicians during their pregnancy, they would have. Those are alarming numbers. And so it begs the question of, again, what are we doing to ensure that the skills, and when I say skills, I'm not just referring to their clinical competencies, I'm referring to their social and interrelational competencies, their cultural competencies. It's very, very important. So I think this is why doulas become so valuable, because they have had the ability to establish trust. They take the time to actually know their clients, know the women that they're working with, and are willing to take on that sort of investigative approach to problem solving along with women when they say they're having issues. And that's something that every woman can value and appreciate and may at any time in her pregnancy need.
I mean, and I think too, to that end, it's also about being collaborative and saying, I have a curiosity about how you're feeling, and then I will walk this path with you. I'm not going to just sort of take that piece of information in and then abandon it, right? It's being able to kind of hold that in a space, to be aware, and then to be able to revisit it, or to go back and question, or and just to have an ongoing conversation. I think from a healthcare perspective, that piece is the thread that often runs through the healthcare part, which is that dialogue of just, hi, how are you? How are you doing? And it's not just to do the physical exam, but it's really that emotional piece and how we engage with patients. That is vital.
Absolutely.
That brings up an interesting question for me. I'm wondering, for the panelists, what type of systemic changes do you think we could make? Because definitely, I feel that the inclusion of doulas in the whole care team is a vital thing that we could do. But some of us know that MDs tend to push back against other specialties coming into the space. They don't, be it NPs or DNPs or PAs, they're not open to that all the time. So what other systemic changes can we make? Is it just pushing for doulas?
I've spoken so much and I have some thoughts on it, but I really want to appreciate the other panelists. So I'd love for you guys to perhaps jump in if you will.
So my thought process, even with all of this, and I'll kind of take it back to where we started. The one thing that when we had this conversation, there was a African verbiage that you used up at the top, at what point do we go back and find out why they are drowning? And being a nurse informaticist, that is one of my roles. We're in an investigative role. We're data defenders. And so what I really think needs to happen, even with these cases and going forward, so that we can get clean data, even though we know that we are getting a lot of data in, is it really clean? Is it really useful? Are the numbers skewed? How skewed are they, right? But going back to your question, what I really propose or think that needs to happen is we actually need to go and look at the case management around these moms. How effective is the case management? Are we offering enough wraparound services, specific to those particular areas or specific to that particular culture, right? And I'm, even though I know that I'm sitting on a panel and we're talking about Black mothers, but this is, minority mothers. We're talking about Hispanics, Philippines. We're talking about all of these mothers. Are we really, really supporting them in the manner that we could in the healthcare system? That is one thing. Once these moms enter into the healthcare system, especially if they come with any of those comorbidities like diabetes, high blood pressure, things like that, they are generally given a case manager. How does that case management really continue through their care? Do they only have one visit? Do they only have 3 visits? How does that really work? Is that case management really, really holding their hand? So we might need to take a step back and just say, okay, do we have case management services that are specific to these pregnant moms? And what I mean is not just general hospital case management, because their cases are super heavy and they have huge loads. We need a coordinator, a care coordinator that can help these moms get everything that they need while they are in your health system.
Absolutely. Navigators are so critical, right? Where they have been deployed, even with other, in relation to the management of other disease states. Navigators, care navigators have been so helpful in that. And to some extent, there then lies, again, another potential opportunity for doulas who oftentimes do take on those roles for women when they're trying to figure out where to go for particular types of services. But how can we further extend that and recognize that that's, a responsibility for the whole of the care team to engage in?
I love that TJ said clean data. I love using the word clean data because using like natural language processing and trying to extract unstructured data, you don't really know what you're actually getting. So I really love that whole process. And obviously the thought behind the clinical quality language is to promote clean data. I agree with Lauren very heavily on the provider training. I think it's really important that we pass additional rulings like the Omnibus Act that allowed for provider bias training. So that medical education under there, but there's still a long ways we need to go. As far as care management, case management, one of the things that I'm trying to do with the clinical quality measures in the initiative is pilot to test their functionality, their impact, their actual real world impact on what's happening before we deploy them with different payers and hospital systems to go in and actually start to show that those additional touch points, those additional visits for case management are valid and it will save the payer, the health system overall long term to kind of break out of that episodic payment thinking methodology. But I agree with every point that everybody's made so far.
So that's a natural segue into our next question. And I would put this specifically to Fran and Holly. What role does public policy play in changing these numbers and making things better?
It takes on a huge role. And again, this is why I emphasize that, as we're saying, okay, for example, we're going to expand postpartum care to 12 months. Okay, great. But what does that actually look like? There's been no guidance or recommendations made around that. So what are we going to get? More of the same? To tell me that I get a couple of extra visits with a clinician who's not really interested in seeing me doesn't resolve the issue. The other thing, again, goes back to around health literacy. We have to have an agreement that health literacy is an area that needs to also be reimbursed, right? There are health educators that have been part of the system for a very long time. We talk about, challenges around getting doulas invited into that circle. Health educators have struggled with that forever. So what are we doing to emphasize and change that as well? But equally, I would say that there's this role and responsibility for other providers of public services that need to also step up as well. The circumstances and the situations of an individual, whether those are economic or physiological, need to be taken into account. So when programs know that they have a soon-to-be mother in their program, then there should be some modifications made to those programs to ensure that those women are getting the care that they require. You know, it was an interesting podcast or interview that Reach did with a group out of NHS, that's the National Health System of the United Kingdom. And during that dialogue, one of the things that they sort of described was how when a mother, and this is any mother, that's what I love the most about it, any mother, when you become a mom, the new baby has arrived, there's someone automatically, the system it triggers in the system for someone to come out and do a visit with you. You're not going to them, they're coming to you. They're calling you, they're visiting with you, and that every woman should be offered that. They're there to talk about the services within their community that are available. That's totally comprehensive, and it's something that we lack here in the US, and I think that there's a lot that we can learn from other markets and other communities that have proven to be successful, but for whatever reason, we're just not deploying here. And this is where, from a public policy perspective, I think we need to challenge ourselves on that. And just lastly, because I'm really curious what Holly and TJ have to say on this topic, is the role of the data in it. There's so much data we sit on. You know, I oftentimes talk about imaging data and how there's, you know, over just so many 10 terabytes of imaging data that's produced in a facility. Well, that's just imaging data. Think about all the other data points within those facilities that go underutilized and collectively have an amazing story that they could tell around the type of care that's being provided or not being provided to women. And yet we're not doing our due diligence in telling those stories.
I'll go off on the data in a minute, but before I nerd into that, one of the things with public health policies, I was listening to the CMS Quality Conference yesterday and the day before, and state policy programs do have the ability, I think, to craft policies that will affect some of these. I know that we do need to standardize that across most states, but I'm going to call out New Mexico because they actually mentioned a program to cover home visiting. And that's one of the things that I think you touched on, Fran, and group prenatal visits. And they have the ability to start to focus, especially with Medicaid being 45% of all births. I think it's like 66% of Black infants have Medicaid. That is something that should be uniform across all of them. So, of course, expanding the postpartum coverage, allowing for those home visiting programs, group prenatal visits, doulas, allowing coverage for doulas supervised or unsupervised, because the outcomes are the same regardless of the supervision. And then working towards the value-based payments and rewards to actually improve healthcare. So I think that some of the states are starting to get there, but it's time for everybody to do it. And when you talk about data, and we have so much data and we're sitting on it, the whole concept of we don't know, or we need to get more data or stratify more data. We have data on disparities. We have data on what can prevent a lot of these things. And the whole I don't know, we don't know. Well, we know some things. So we can start somewhere, and along the same lines, we can collect additional data and just build and learn from it.
That actually, Lauren just mentioned to me that the AAMC actually is calling for studies on, or clinical trials on this particular issue due to a lack of data. So I'm always wondering why there's always this, oh, we don't have enough data, when we're inundated with it. What's going on there, guys?
I think we have a lot of data points. So let me clarify that. We have EMRs, we have inpatient, outpatient. Pretty much, if you're a healthcare organization, due to the HITECH Act, you have had to have a electronic medical record mandated, right? But the problem is with the data that we are collecting is, A, is it in the right format? B, is it shareable, right? Those are the two major things that we're missing. C, the data that we are collecting, is it being used properly? Is it being analyzed properly? And that's the core of what is really happening. We have so many data points. I'm gonna slap my hand on this one. We probably have too many data points. I'm gonna be honest with you, okay? Because some of the data that we have coming in, it's not really useful, right? We're just collecting to be collecting. But the key behind it all is the analysis. We have all this data, but we don't have the right people looking at it, asking the right questions. a great data analysis person would be asking questions about, okay, I have all of this data. What is it that I want this data to tell me? Then that's when you go in there and you start to break the pieces out. You start to lay the story out of the data for it to speak to you. So
that's, you're spot on that. Again, I just go back to, when I refer to the story, I'm referring to the analysis, right? We're not telling, the data is there. We're just not telling the stories of what that data is telling us. We're not pausing to analyze it. And so, but I would also equally at the same time, I totally agree with Holly. We have a sufficient amount of what we know today to be doing much more than what we're currently doing. But it does require for their, different from Medicare, Medicaid is decentralized. So states basically do what they want. And so for some, they're doing less and others are beginning to do a little more, but they're also doing it inconsistently, even within their own states. So you'll see in places like Kansas or South Carolina or New Mexico, where programs get implemented, but they're really only implemented in certain regions or hot spots of that state, where we need for these programs to become more statewide, more prevalent, right? And so this is, equally part of the problem. And it doesn't just, it's not just, it shouldn't be just, oh, here's a program for urban communities, or here's a program for rural communities. Well, if you've got a substance abuse problems, you likely have those in both communities. So these programs need to be broader, and they need to be more long-term, and in some form or fashions, sustainable. That's another element. We throw in a little bit of money because we allocate it for a fiscal period of time, and then when that money is exhausted, the rigor hasn't gone around the evaluation of it, and no provisions have been made for those programs to continue even when they are successful. And that just doesn't work.
I think a lot of the state programs need a little bit of guidance too, because what I've seen is kind of scary on how they're implementing a few things. And I think it's going to take initiatives and people like us who are passionate about it to go in, if they listen, that is, and kind of give some guidance on, one, the clean data. What is the actionable data? What is the story it's telling? What can we collect at the same time that we're implementing it to change the outcomes now with our clinical quality metrics, but also pave a new path in the future with what we're getting. And we're getting the right data. So we're just stratifying it out. And I agree with TJ on having too many data points. You have to know what you're looking for a little bit before you actually start to look for it. And a lot of times it will tell a story on its own, but we've got to be looking at the right things too.
The one thing that I want to add is I have implemented electronic medical records for the past 15 years, and my specialty is women's health. And the one thing that kind of, makes me sad a little bit is women's health is the last to always be implemented in any hospital organization, right? We are the number 2 to bring in the finances, but we are the last to get the technology and the data capture for these arenas. So I think that speaks volumes in itself.
Yes.
Because of Medicare too. So sorry, I'll stop in a minute, but this actually blew my mind when I got into the prenatal space, because I began writing the technical specifications for electronic health records when high tech came out, and did the certification for 2011 all the way through, and consulted in like 18 different specialties, but not much in prenatal care. So once I got into prenatal care and noticed that there's literally no structured language in electronic health records, that's what really prompted this entire initiative, because it blew my mind. And it's because everybody's incentivized through Medicare. Maternal care is Medicaid, and it's divided.
Right.
But I agree completely.
So that brings up our next question, which is much in line with what each of you is saying. What role can health IT, because we're trying to stay person-centered, right? But what role can health IT, data governance, and AI play in maternal mortality?
Well, I'm going to do a shameless plug here. We need nurse informaticists and we need them badly. like I said, I've been a nurse informaticist for 15 years, and we've kind of just been piddled around in the healthcare interdisciplinary team, and nobody really knows what to do with us, right? And I keep saying, hello, let us look at the data. Let us tell you what it's saying. And that's what really, really, truly needs to happen. So in my career, a lot of times I was called in on these women's health projects. And when I came in, the first thing that I did when I came to the table was, okay, let's look at the nursing workflow. When the patient comes in, right? What is it that we need to capture from the patient from when they hit the door to when they get ready to leave, right? What are those wraparound services that we offer? Let's bring all those stakeholders in, right? PT, OT, case management, dietary, if they need a specialist. Okay, so when we chart all these things in the chart, then how do we notify all these providers? How do we keep in contact or make sure all of the interdisciplinary stakeholders are aware of the care of mom, right? Even down to the mental health space. So we need nurse informaticists in these spaces leading the charge, especially in those arenas of electronic healthcare, healthcare IT, because we know the workflows of those patients. We know when they dot that door, we know what they need when they come in. I'll tell you a really quick story. I had a client where they had an ED and they wanted to bring the moms in through the ED. And I was like, wait, we don't want any pregnant moms sitting in the ED. And they said, oh no, it's no big deal. I was like, no, you guys better change that. We need to change it now. So, we can help with things like that. But our biggest thing is just that data, being able to take it, scrub it or clean it, as Holly says, and then being able to tell the story back to the organizations to say, this is why these additional services are needed.
And I'll make mine quick and not completely nerd out, but this is where I get really excited about things. But just the option of being able to take this and make it interoperable and then create clinical decision support tools, which can then literally automate itself to order a specific test. It could be bi-directional and integratable with the result coming back in. If that result determines this specific thing based on evidence-backed management, then it could literally automate a referral out to a specialist, or it could send a notification through their portal to a patient to request additional appointments. It's really cool when you start to think about what you can actually do once you make the data interoperable, and some of the digital diagnostics and tools that can come from it is pretty cool.
Holly, I'm a nerd too. So don't.
Yeah, I can tell you and I speak the same language.
Healthcare is not just within the four walls of a clinical system. So care begins, where you live, work, play, and pray. And when you think about where problems show up, problems don't decide to show up when you're at the clinician's office. In fact, they usually show up when you're outside. And then when you get there, whatever the issue was is gone. You don't know how it resolved, but somehow it just sort of resolved itself. So I think that the real opportunity here equally, right? I think the back end things that we refer to are absolutely necessary and are needed. But I think that there's a tremendous opportunity that we're not taking advantage of, and that is, creating for smart communities and creating for and leveraging the technology that's in our hands, and utilizing digital health platforms, remote patient monitoring, utilizing digital support systems, utilizing teleconsult. These are things that most clinicians are not comfortable with. So again, when we talk about, increasing the level of competency, in addition to cultural competency, digital health competency is something that we need to put a spotlight on. During the pandemic, we did quite a bit of research and looked at both ends. We had a study that looked at what were pregnant women doing in the midst of COVID. They were scared. Many of them wanted to use digital health. In fact, 80% of them would have liked to have used telehealth or some form of digital solution, but their clinicians weren't utilizing it, didn't make it available to them. So we did the reverse. We looked at the other side of the coin. We went out to obstetricians and gynecologists and asked the question of them around their thoughts around digital health. Many of them, I would say about the time 60+% saw the value in it, the majority of which, over 85%, didn't feel that they were comfortable with the technology, that they needed to have more education on it. And they also were disgruntled about the lack of reimbursement. They were unclear about how they would be paid for utilizing these systems. Again, areas of which, when we go back to policy, there hasn't been enough done around it. I mean, just what, is it just today or no, is it today or is it the 16th? The question around, the extension of just telehealth in general, which is not even reaching the majority of the population. We like to talk about it in millions because there are millions of Americans, but the reality of it is that less than 30% were actually using telehealth during COVID. Yes, at an absolute number, it's a large number in the absolutes, but percentage-wise, it was still an insufficient number that could be using the technology. And in women's health and in pregnancy in particular, it's one where it is being underutilized. And so I'd like to see, more that's done there. We have some states like Tennessee, as an example, has a bill that's being proposed at state legislature, which would look at the use of it. But we know the benefits, the efficacy is there. It's been there for a really long time and it's not being deployed. So I think coupled with, making sure the data is shareable and accessible, it's making sure that it is collectible from all the places where it exists. And that's equally in the homes of women. So I'm hoping there's more that we can do around that.
I think we should start too, and this has been brought up, but reimbursing for provider training a patient how to use the digital technology, I think is a big push for that too.
Mm-hmm.
Okay, so at Hit Like a Girl here, we like to take actionable steps, give you all some homework, how we can get this movement going. Dr. Hebe has an interesting take on the trust factor. So Dr. Hebe, can you speak to that?
Oh, absolutely. I'd be happy to. Thank you. I appreciate it, Therese. So, in relation to the trust issues and gaslighting that we talked a little bit about earlier, so 70% of pregnant moms go to the doctor the first time in the third trimester. That's pretty abhorrent. That's pretty abhorrent, isn't it?
Yes.
So that goes to tell you that every touch point that you have with the patient is vital. And so what I believe is that there is enough care, there is enough data and enough clean data to demonstrate, and enough research to demonstrate that we need to advocate for care delivery redesign. And that to build as a mechanism to build trust. So we think about things from a policy perspective, the data perspective, outcomes, access. I think so much of this has to do with reimbursements. It has to do with, is care really accessible? Is it really? Just to say it's there, and whether it's there or not. But if you don't lead the path to people, but based upon what they need, is it really, really there? So it's care delivery redesign. There's policy issues, there's reimbursement issues, and then there's just generally disrespect and disregard. That sounds really kind of harsh, but I'm kind of a friendly but blunt gal. So I'll kind of share what I have heard and how I've tagged a few things. So women are not heard, and then especially pregnant women are really not heard. And that starts some sort of a vicious cycle. So you're not heard, they don't intervene. When they finally do intervene, they're not treated, okay. And then that wants us not to voice, and then that cycle, that negative feedback loop that kind of continues. So it's not just an issue of health literacy, it's also an issue of IT literacy. And access. So, I remember in 1999, we were talking about broadband, and we heard in COVID, wow, a whopping another 250 million was going to be instituted by the government for broadband. I'm like, this is 2021, 2022, right? And I mean, we're still here. Put your money where your mouth is. The health, we matter or we don't matter. And we matter through actions, trust built through actions. I really genuinely am advocating for care delivery redesign. How do we create birth-friendly environments of respect and trust? How do we create and reimburse? How does policy for care delivery options, how are they paid that are genuinely person-centered? And culturally empathic, do we really want to know that? We know about doulas. My daughter just had a baby, and there was that doula right there. I'm telling you, every moment, the mom, this is what the mom wants. This is what the mom, and she wasn't demeaned by Becky, or she was the mom. She was the patient. She was supposed to be the leader of the team, the patient. Midwives, centering care, home births. How are we looking at organizations, looking at data available to understand what is available to us? And whenever you do have policy behind it, then other infrastructure kind of comes behind it. How we look at quality and how how things are monitored. I want to share a little vignette that I heard about a woman with transportation. So mom doesn't show up for her 6-week postpartum visit because she just didn't want to. Okay, that's what they wrote in the chart, or that's what they checked. Patient refused, patient declined, whatever. Patient was offered transportation, so clearly she must have been non-compliant, right? But the reality of it was that she was offered transportation for herself, not for her baby, and or her 3 other children that she had at home. So it was either go to postpartum visit, but she was offered transportation. So, I mean, do we really understand what that means? Are we looking at things in a 3D dimension? Or are we looking things in a checkbox, in a 2D? Yeah, I really gave her the transportation. I think that we have to think about things in care and trust, and how are we genuinely defining person-centered care? And I think that, again, trust is built via actions. Because for sure, distrust has also been built via actions or non-actions. So the converse would be true. Well, I have so much to share, but just in general, thank you for the opportunity to just speak on the trust issue through actions.
Thank you so much for your comments. So everybody else, also to that vein, what actions can we take?
Well, the first one I would say from my end is everyone needs to be writing to their, their congressperson, right? Writing to their senators, letting it be known your position on these issues. I think that the remarks that were just made were very much spot on, and that we need to make sure that our voices are being heard. If we believe that care could be better for the people in our community, then we need to speak up and say that the care could be better and outline some of the ways in which it could be. And when our politicians aren't representing us in the fashion that we expect to be represented, then we have to question who are they representing and stop putting them in office.
Final thoughts, TJ?
I would say the quickest impact would be to educate yourself. All of us have a friend, a mother, a cousin, somebody who's in that childbirthing stage, that you're close with or you've seen from afar. And just educating yourself can help them. Each one teach one. That's what, my mom and my grandmother taught me. Each one teach one, and you can help walk them through this, because I get so many calls every day talking about, hey, they want to give me all these signs and symptoms, and then, I try to walk through them with them, but then I ask them, how much do you know? Have you tried to educate yourself on this topic? Because yes, we love providers. I'm a registered nurse. I respect providers, but at the same time, we are all practicing medicine.
Excellent. Holly, your final thought?
Probably shouldn't say this, but I'm going to, of course. A way that I've found, instead of relying on public policy, which I think is incredibly important, and relying on our representation in that, some of the ways that I found to be creative is finding vendors that have similar passions, that have the ability and the funding to make a difference. And that's one way that I feel like some action can start to be taken, is once you find somebody that has similar beliefs, and then you're allowed to kind of be exploratory with how it can actually better outcomes with it. That's the quickest way that I found to actually make a difference.
Awesome. Fran, take us home.
Yeah, so I just want to give a moment to women's power, right? We're all here because someone brought us into this world, women have been, having babies since the beginning of time. Least we forget that. So I really employ us all to remember that, yes, there are all these challenges that we have, but just like, TJ is saying in relation to, educating yourself, we just have to remember that we have the ability to do this, whether the system chooses to participate or not. We can choose what our care journey is going to be like. And that just requires us to be stronger as women and as a community, and equally with the men out there who are supporters and equally share in our desire to make for, the health and well-being of both ourselves and our families.
Well, that's going to take up our time. I want to thank everybody for joining us, our panelists and our invited guests, Lauren and Dr. Hibby. Thank you so much for your remarks. If anybody else wants to send questions along, we will pass them along to the panelists. This was amazing to me. I would hope that some collaborations will come out of this. Please get in touch with the other people in the chats if you want to work with their organizations in any way, shape, or form, or reach out to Hit Like a Girl and we can pass along the information for you. I want to thank my co-hosts that sit in silence, Robin Roberts, amazing, and Joy Rios, who is in this room 15 times, but I love her. And thanks to everybody for joining us today. This is amazing, but please continue the conversation because we intend to solve this problem. As Fran says, there's no stopping us. We are going to take care of this particular issue. We look forward to seeing you around Hit Like a Girl Pod or in your spaces. Thanks for joining us, everybody.